Now, may I invite Dr. Ramesh Kekunnaya, who is heading the Child Sight Institute in Hyderabad, to enlighten us on cerebral visual impairment, please. Sir.
Thank you, Sumit and AIOS for this opportunity. This is a very rare talk and rarely spoken. I'm going to give a little bit overview of my baby can't see what, why and how, and specifically due to cerebral visual impairment. As we saw, different child needs different approach, and especially when the child is having some kind of difficulty even with the routine things, even showing eyes and even moving the hands, we need to have different approach. As Sumit showed, sometimes darkening the room can give you a clue like that, where this nystagmus manifests only in the dark room. This is vertical nystagmus. It's one of the things which can be seen in retinal dystrophy. So whenever you see a visually inattentive child, examine them carefully in a bright light as well as dark light. We may not know what exactly is happening for this patient. Obviously, all these details in a child, we can talk about all this, but in an infant and a juvenile, getting all these things is a difficult thing. Sometimes you can't even do a 90D or 78D examination. We'll have to rely on our indirect ophthalmoscope and get the relevant data. It's also important, see this child. The child is struggling. Somebody is holding the neck. Probably it's not a correct way to examine this child. See, the child is not. The child is wearing glasses, but child has a posture. There is a seeing area and a non-seeing area. It may be better off, child is giving some response sometime. It's best to examine them flat on a table or on a mother's lap, a little bit comfortable level. Otherwise, it's difficult. You can estimate, but it's still making them in their posture, it's very, very important. Sometimes you can look at the brain like this, and you can always say that this child will not see anything. But the same child can look at many of the things, even the saccadic movements are there. One thing you need to remember is there are two things, ocular visual impairment and cerebral visual impairment. Ocular is, many times we do a cataract surgery late in life, they have only ocular problem. They don't have hypotonia, hypertonia or any one of them. Their chances of visual recovery is better because their other systems are very nicely working. When you talk about cerebral visual impairment, if they have a prenatal, this is a prenatal, it's a porencephalic cyst. This is a prenatal. If there is a prenatal insult, the chances of visual recovery is much better than a post-birth or post-delivery insult like hypoxia. This child does not have more than 50% of the brain, but still the response is very good for this child. So we'll talk about how do we reach a diagnosis. This is always, we have spoken already, searching eye movement, lack of fixation behavior, normal and abnormal. You know, by looking at the child, you know, even with the photograph or a video, this child is normal or abnormal. It's very easy to look for these things. And additionally, they can have a range of refractive error ranging from minus to plus. Sometimes in the whole search of examination why the child is not seeing, these important and the simple refractive error can be missed. Look at this child. The reflex is quite good. There is a nystagmus, vertical, horizontal aphakia. Ocular visual impairment is treated completely with the treatment. Look at this child. This child has a cataract. Look at the movement. Even this child had some delayed milestones and things like that. Even after taking out this cataract, there is a combination of ocular visual impairment and cerebral. In congenital cataract, we see this combination very, very commonly. Parents say that you have done the cataract surgery, we should get the child's vision, but it does not happen in some of these patients. So this already emphasized the part of what we need to do in all these cases where the other causes can be ruled out. And sometimes you don't have to examine anything. If you see something like this in retina, you can come to a diagnosis, whether it is ocular or cerebral visual impairment. The most important part is this child, where there is an insult here. You can see a significant insult here. Low birth weight child. Seizures. One of the treatment for cerebral visual impairment is finding out what is the dosage, what is the reason of seizures. If it is an infantile spasm with cerebral visual impairment, just by treating that infantile spasm, sometimes the vision improves significantly. And as an ophthalmologist, you need to remember two things. All these children should get an EEG, because 80% of the cerebral visual impairment children have a chance of epilepsy. Second thing we need to get is hearing test. These two things we need to include in our assessment for this patient. And they will have this drooling of saliva. By face you can make out if you have seen many patients, and they will have usually microcephaly. Imaging, I think it's very, very important in my opinion to know where is the damage and how much is the damage in each of these areas. Then you can delineate what kind of, whether it is a dorsal stream or a ventral stream, you can try to get some information. So this is basically a disturbance of vision caused by defective function of the retrochiasmatic portion of the visual system in the absence of important ocular diseases. Exception to this is some of the cases of glaucoma, some of the cases of pediatric cataract. They can, as I already said, they can have ocular visual impairment as well as cerebral visual impairment. This is the dorsal, and we know V1, V2, V3 are the most important areas of visual cortex. They are connected through the inferotemporal cortex to the ventral. Ventral is always what, and dorsal is always where. What and where. What do we see? Where do we see? So these are the areas which are connected. This is one of the nice articles written by our colleague Niranjan Pehre. This is available in IJO. I advise all of you to go through this. What it gives here, occipital cortex is visual acuity, field, color perception, contrast sensitivity. But this part, it gives what? Recognition of faces, objects, shapes and roots. But if you want to have a visually guided movement, the dorsal stream is very important. 3D internal map of the visual world, visual attention to the object of interest. There is an object. If you have to keep your interest there, you need this dorsal stream. What and where. And these are some of the simple tools what can be used to evaluate these patients. Remember that room should be clutter free, as well as even simple mirror test can be used for the evaluation of this patient. This is basically what is the features of dorsal stream dysfunction as well as ventral stream. You can see what and where. This is about ventral. Here what happens is there is an impaired recognition, difficulty in recognizing people. Even if you show their own mother's picture on a laptop or a photograph, they can't identify. So there is a difficulty in recognition, and they tend to lose in, this is a higher visual function problems they can have, they tend to lose in crowds. If you look at the scenario, the most common cause is perinatal hypoxia. So as we are creating more and more awareness about ROP, I think creating awareness amongst obstetricians and gynecologists with regards to perinatal hypoxia, I think it's extremely important. We talk about, suing, ROP, all that, but creating cerebral visual impairment, having a neonatologist by the side of, even if it is a normal delivery, we have to have this system, because this is almost, this is in one of the paper, not from India, but this is significant. This is from US, but still see perinatal hypoxia. In our group, if you see, it's almost to the tune of 70%, which we have to talk. There's one suing of a obstetrician is enough to create awareness amongst that. That's the only way it works, unfortunately, here. But we need to advocate that part to prevent, because whatever we have said and done, this is important. This slide is important because they can have microcephaly, cerebral palsy, hypertonia or hypotonia of the limbs, you can feel it. But the seizures, look at this, in this series almost 50%. And hearing loss, even if it is 1%, for that child with the hearing impairment, it makes a difference. That's why getting that done is very, very important. This is something ocular, the refractive error, Sumit spoke about nystagmus, esotropia, exotropia. This also is important because many of you would have seen, just by treating the esotropia, the child's behavior improves significantly in this group of patients. Excuse me. So this, I'm not going into the details. This is a multi-system rehabilitation, which Shailja probably will talk about. But I just have two things to say. Don't do all the evaluation in one visit. First visit, do a good retinoscope. Take a good history, send them to a neurologist, get MRIs done if required, or EEGs done, or a hearing test done if required. And most importantly, do a dynamic retinoscopy and give a good refractive error correction. This is the first and foremost thing as an ophthalmologist we need to do. When they come second time, involve, maybe in the same time you can involve your rehab group, give them the questionnaire, what are the things. Don't call them after 3 months or 4 months. I'm talking about call them in 2 weeks time and do the evaluation for low functioning or high functioning, whatever the problems are. Specific treatment plan you need to create for this patient. Sorry about that. So then involve your group of people, and then look at the behavioral characteristic of these patients and give visual rehabilitation depending upon the problem the child has. I am not going into the details of this. Even this part I am not going into the details. Probably this is one of the very, very important flow chart developed by Mike Brodsky, where you can apparently blind child, two things you need to do. There is nystagmus or not, that's the first thing. Then anterior visual pathway lesions you can always look at, looking at the retina or the anterior segment, optic disc, you can really see. If there is none, there is no nystagmus, anterior visual pathway is normal, then the next thing, obviously these are all, not that you will go in a systematic, you will definitely ask about prematurity, hypoxia, all that in the history. Then there are 3 or 4 things: delayed visual maturation, cortical visual insufficiency, or it can be congenital motor apraxia or periventricular leukomalacia. This is the way you can, and this is the most common differential diagnosis we come across in the patients of visually inattentive. This is a kind of important things for a significant visual loss and their differential diagnosis. So I think we need to remember pointers to the poor vision. Meticulous history and examination is required. Do one thing at a time. Don't overdose that child with everything in the first visit, and take step by step team approach required for the diagnosis as well as management. Thank you very much. I take this opportunity to invite all of you to 4 important meetings. This is the 3rd grand rounds in pediatric ophthalmology and strabismus in Chandigarh in August. And we have a strabismus surgical workshop in LV Prasad between 7th and 9th of May. We have a pediatric cataract surgical workshop between May 21st and 23rd of May. And also a World Congress of Pediatric Ophthalmology, which is going to be in Amsterdam in October. Thank you very much. Thanks again for the opportunity, Sumit.
Thank you, sir. As always, very crisp and very, very informative. I think what we'll do is we'll just keep the discussion, just towards the end, and just to go with the flow, I'll now invite Dr. Shailja Tibrewal to enlighten us on a very, very important topic. I've kept it as a separate